Welcome everyone. I am Andrew Duckworth and I would like to thank you for joining us for our special series of BJJ podcasts on the COVID-19 pandemic. As we've already discussed in our first overview podcast with our Editor-in-Chief, Professor Faraz Haddad, the impact of the COVID-19 pandemic is being felt throughout the world and without doubt will have affected every facet of our professional and personal lives. Through these podcasts, we hope to reflect on the main issues that have arisen as a consequence of the pandemic for us in orthopaedic and trauma surgery, as well as on our profession as a whole. This will include the impact of our day-to-day clinical practices, as well as the effects on research now and moving forward in the future. You'll be hearing from colleagues throughout the UK, as well as from across the globe, including hearing from surgeons working in some of the worst affected areas. We also feel it's an opportunity to discuss the future in terms of both the recovery phase following this and what we can anticipate moving forward. So today I have the pleasure of being joined by one of my editorial board colleagues and the Editor-in-Chief of BJ360, Ben Ollivere from Nottingham, who without doubt will be able to give us some great insight into the impact of the pandemic on the challenges we are facing each day, particularly in terms of trauma service delivery, the effects on training for our junior colleagues, and finally, what is in store for us moving forward. Many thanks for joining us today, Ben.
No problem at all. Always a pleasure, Andrew.
So, Ben, if we could start off by looking at trauma and orthopaedic services in particular, if we could just discuss the consequences you've seen and the changes that have occurred, and particularly sort of focusing on our subspecialty interest in trauma.
Yeah, so I mean, it's a different world, isn't it? The whole world changed about 3 weeks ago. Not necessarily on the day that we were told there was going to be a lockdown, but in the NHS, a few weeks before. Certainly in our institution, we started planning for this within orthopaedics around about 4 or 5 weeks ago, which I think has stood us in good stead. Actually, we've always been one step ahead of what the hospitals asked us to do. And we've been able to engage with our colleagues. As you probably know, at the Queen's, we're split site. We have 2 hospitals. So the Queen's Medical Centre is essentially an acute hospital where the trauma services are housed, along with Hands and Pete's, because the Children's Hospital's there. And at the elective centre at Nottingham City Hospital, we have our elective colleagues. I think the biggest change, actually the most positive change, is the way everybody's pulled together. So as a group, about 4 weeks ago, we met. We've had some of the best attended directorate meetings that I've ever seen in the 10 years I've been a consultant there. And we've all just become trauma and orthopaedic surgeons rather than splitting into trauma and elective. And I think that's been a key consequence and a key positive consequence of the problem, I guess, is that I've been very proud of how our department has pulled together as a department. In terms of what's happened to our services, which was essentially, I think, what you're getting at, the elective services essentially stopped. We made a decision as a trust around about 3 weeks ago that we would draw to a close all elective services, and that actually includes cancer. So our trust is a big cancer centre, and all non-urgent, how on earth you can describe cancer as non-urgent, services were stopped. And we expect at the same time with trauma, we expect to be working on a skeleton trauma service. I was involved quite heavily, along with Dan Deakin, in the rearranging of our trauma service. What was felt by our trust and the representations that we made was that talking to colleagues in Italy, and I have some collaborators in Italy, and also colleagues in other countries who sort of a little bit ahead of us in terms of the COVID wave as it is, we felt that we would see likely a massive reduction in minor injuries, and that we would see initially a reduction in fragility fractures, and then as the pandemic moves on and people start to lose their social support, we're expecting to see an increase in frailty fractures. And of course, in trauma and orthopaedics, we're also fortunate to care for some elderly patients, and then that means that we are caring for patients who have COVID, as every other institution is, and probably uniquely in trauma and orthopaedics, we're faced with acute operating on patients with COVID, which obviously is the hip fracture population. So I think that's the biggest change in working. Do you want me to run into specifics, or?
No, I think that's good. But I think actually I would echo that. I think that what we found here, as you know, we have a similar setup in terms of trauma and elective or arthroplasty type surgeons, and then actually the way that the collaborative and everybody's got together to move forward it's I think one of the big positives that's come out of it. Actually, I agree. In terms of, if we look at, just talking about a bit about trauma management, the two things I would want to talk about would just be how your trauma pathways have changed, both for major trauma and sort of day-to-day trauma. And then we could maybe talk about neck and femur fractures in particular.
Yeah, no, absolutely. So, so just talk about the major trauma pathway. Nottingham is slightly unusual insofar as, one, it's a very busy service. So we manage about 1,600 ISS 16 plus patients a year, which makes us a huge MTC. And so we have a separate MTC service, whereas in a lot of places, the MTC service is housed by a specific specialty. We have our own specialty of major trauma, which includes consultants from various different disciplines. So I act on that rota, as do a couple of orthopedic colleagues, and we have intensivists, plastic surgeon, vascular surgeons who run an acute 24/7 consultant-led trauma service. So one of the sort of differences, I guess, between having a larger service that's therefore better funded and has more people involved than a smaller service is we're able to offer consultant-led resuscitation 24/7. And one of the key advantages when we were planning for this is that we therefore have a consultant major trauma surgeon available 24/7. And so one of the first things that we've done is change our triage pathways. So our triage pathways to reduce the burden on the ambulance service, and also to try and offload the MTC, which is essentially the hospital last resort, whether that's for a respiratory patient or whether it's for a cancer patient or whatever, was that we, rather than doing our standard pathway, which is, send and phone. So because we're a big centre, we have an open door policy for referrals. So the phone call happens after the send, hence send and phone. We've gone to phone and send. So each patient that's transferred is run past the major trauma consultant prior to their transfer. Okay. We anticipated a significant drop in trauma calls, and we've had a significant drop in trauma calls, going from kind of 10 to 14 every 24 hours to probably 6 or so every 24 hours. We didn't anticipate as much of a drop as we've seen. If you look outside your window, you can see the roads are empty. And the few people who either have to go to work or are breaking the lockdown haven't got anybody to run into, as far as I can see, because no one else is on the road. So there's been a dramatic reduction in trauma calls, and that obviously wasn't something we anticipated. And perhaps going back and revisiting it again, we might have acted slightly differently in that way. So that's the major trauma service. Yeah. So the second part of your question was
the sort of day-to-day fracture management, particularly in terms of, I suppose, fracture clinics and things like that.
Yeah, so day-to-day fracture management, we did a couple of strategic things early on. We moved, and I managed this move actually, we moved our orthopedic trauma services out of fracture clinic, which is co-located with A&E, and we moved it to our independent treatment centre, which is on site. Okay. And we made that a COVID-free pathway, a COVID symptom-free pathway. And at the same time, we moved the minor injuries pathway from A&E, and we took the minor injuries pathway with us, which is essentially doubled the size of A&E, because the GPs, and an absolute credit to our local GPs, took the minor illness pathway. So our A&E doctors are no longer dealing with minor injuries or minor illness. They are just dealing with major injuries supported by our on-call, and major illness, i.e. COVID, and they've got twice the space to do it. So we set up the minor injuries pathway co-located with A&E. We were able to requisition a few nurse practitioners who we've upskilled. And what we've done with the assessment pathways, I've put all the pathways together. So instead of multiple trips around the hospital, multiple x-rays, multiple follow-up appointments and consultations, the nurse practitioners essentially act as a triage service. The patient comes in, they're seen by the nurse practitioner. They are then triaged to one of 8 different pathways. So I think it's 8 different pathways. So we've got an EMP-led pathway for things like cuts and stuff around the face, removal of foreign bodies from the ear, and that sort of stuff that we don't do, essentially. We've got a limb injury pathway where the patient is then triaged directly to X-ray. If it's a significant injury pathway, then sees a consultant orthopedic surgeon immediately afterwards, has their treatment instigated, no requirement for virtual fracture clinic because the decision is made there and then. Yeah. We've taken over the acute plastics pathway. So for significant plastics injuries, they see a plastic surgeon right away. Similar approach. We've done the same with a hand pathway. So hand injuries, instead of doing the typical thing of coming backwards and forwards many times. They get a consultant-led opinion right away. And we've done the same for a minor lacerations pathway, and also for the elective orthopedic problems, because one of the difficulties with just turning off elective surgery is if you don't turn off elective surgery 6 weeks before, you've still got large cohorts of patients going through, coming back and needing their elective follow-ups. We felt we wanted to provide a reasonable pathway for those patients. And in fact, because our elective orthopedic colleagues are acting as the consultant for the minor injuries pathway, they're able to deal with those things almost right away. Mm-hmm. We haven't yet had to turn that pathway on because we're still able to staff the city hospital a little, and so the elective problems are still being managed as they were before. But we expect within the next week or two to turn that pathway on, and to deal with things like infected joint replacements and stuff that may not be post-operative problems, but are acute orthopedic problems that need to be dealt with. At the same time, we opened a ward at the treatment centre. And we did two things with regards to theatres. We decamped our ambulatory trauma pathway to the treatment centre. And because anaesthetists are in hot demand at the moment, and we reckoned we could do a lot more with consultant-led local anaesthetics and or regional stuff, we also staff a theatre without an anaesthetist. Right. So if you're on the hand pathway, for example, you will get your tendon repair done by the consultant hand surgeon that sees you an hour after they see you, because that sort of thing can be done under regional. So that's improved our efficiency. A couple of mistakes that we made. We instituted a virtual fracture clinic, and we've always known in Nottingham that the Scots are entirely wrong about virtual fracture clinic. We've been pretty clear throughout that you guys are not doing what you should do. And so we thought we'd follow the crowd and started a virtual fracture clinic about 4 or 5 weeks ago. That's morphed into a virtual triage service, because the virtual fracture clinic, essentially by taking control of the minor injuries pathway, the virtual fracture clinic got no one in it. Mm-hmm.
Right.
Because essentially all those decisions that take a little while, you have to phone the patient and what have you. Actually, you can eyeball the patient for 2 minutes as they come through in the plaster room. It takes 2 minutes, and you go, vertebrae ankle fracture, stable, don't have a plaster, have a boot, here's your information sheet, you don't need to come back.
Yeah.
That's it, and all done at the same
sitting,
the same thing. We do have a triage pathway which we're running like a minor injuries pathway for between 8 p.m. and 8 a.m. when there's no consultant there but there's a registrar there. Mm-hmm. And those patients are triaged to a number of specific pathways, like the soft tissue shoulder pathway and so on, that again we've instigated since we started. We've done a huge amount of work on our pathways. Yeah. And actually a lot of it we're going to keep, because we think our patients are getting, without doubt, better care than they had prior to this. We can't keep it all because essentially, in order to achieve that, our elective service is entirely shut down. Yeah. But we're hopeful we'll be able to continue to provide better care, because one-stop shop is much better.
Yeah, the patients, like you say, it's much better for the patients. Just moving on though, Ben, how have you been managing your, like you say, I think in our specialty it's unique in terms of the neck and femur fracture patients. The COVID positive patients, elderly patients, pretty unique, and in terms of our specialty that we still will be trying to operate on those. What's your how have you dealt with it in Nottingham and in relation to the guidelines that have been put out there?
So there's a couple of things in terms of operating. One of them is we started off, and there was a bit of dissent amongst the group, which is unusual. We're normally pretty cohesive as a group of consultants, and some of us felt that we should be much more conservative because of the coming tidal wave of COVID patients. I wasn't in that group, as you'll probably tell by my facial expression. I felt that there's a window for most orthopedic surgery of around about 2 weeks for most orthopedic trauma surgery, and what we should do is be as efficient as we can, operate as much as possible, anticipating there'd be 2 or 3 weeks when we couldn't operate and some patients would suffer. Yeah. As a group, we decided to go down the conservative option. We reversed that decision about 7 days in, and went back and operated on everything that we decided to treat conservatively, because we're a conservative group to start with. We don't operate on much that we see. And we relearned some of the reasons why we would operate on some of these things, because we had lots of early slippages in plaster and so on. And we also discovered with the ambulatory patients, the thing that I guess we all know but don't necessarily need to be reminded of in order to remember, is that non-operative management is not seeing the patient.
Yeah.
You know, and if you're trying to keep the patients out of hospital, putting them in a plaster when they need to come back reviewed every week, as opposed to putting 2 K-wires across their distal radius fracture, you're better with the K-wires, especially if you do it under regional.
Yeah.
You know, they get it right away. They get their manipulation, their K-wires and their plaster. They don't come back for 5 weeks. So that's the sort of ambulatory stuff. The neck of femur stuff, we went through a similar sort of route, although we never ended up non-opping any of them, but we talked about what we might do if we had no access to theatre. We've upskilled a little bit in terms of reviewing traction, teaching our nurses, that sort of stuff, you know, things that we haven't been doing for a long time.
Yeah.
We were sort of lucky, although we perhaps thought we weren't lucky to start with, which is the trust made the decision that one of the first COVID cohort wards that we would have would be one of our orthopaedic wards, which was how we managed to get a COVID-free ward at the treatment centre. And actually that's worked out really, really well. And anybody who's listening to this and, you know, wards are expanding, then I would thoroughly recommend that's a good method, because the reason they did it actually was because they saw that we had some clinicians, you know, the orthogeriatricians that weren't really, as far as the trust were concerned, were kind of redundant, because they never really understood why you need 2 consultants to look after neck and femur patients. And the only reason they do it is because of the uplift of tariff. But what we found, of course, is we've got really good relationships with our orthogeriatrician colleagues who are running one of our wards, was our wards, but it's now a COVID ward. We've got somewhere to put our patients who, you know, we had a patient just the other day came in with bilateral wrist fractures. You know, you can't leave that patient in plaster, especially as she was 75 on her own, and she had COVID. And she was diagnosed with COVID on her admission. So she needs somewhere to go post-operatively. She's not got a bad case of COVID, but nobody's going to let her into a clear ward. And so that was perfect. You know, she came into the COVID cohort ward. She had her wrist sorted out. She was sent home same day, and she's now a bit more able to care for herself than she would have been if she was just managed in plasters. So we're being pretty aggressive about our neck and femur patients. So one thing we're not allowed to do, because of how the trust views COVID as a risk factor, is we're not allowed to operate in orthopedic theatres. So we have COVID-specific theatres. Yeah. And again, we're a big trust. We're quite lucky. I don't know how many theatres we've got, but it's pushing 70, I think. You know, so a lot of those theatres are going to be used to ventilate for patients if we end up with a surge. But we're quite fortunate for capacity to operate in cancer theatres and stuff that we wouldn't normally operate in. Yeah. So there are, I think, 2 or 3 COVID theatres on the Queen site, and there's 2 on the City site. Yeah. So you just list the patient in the COVID theatre and off you go. I think the idea of leaving somebody with a viral pneumonia in bed, and it's no different to anything else. You treat them as you would any other patient. You fix them so they can sit upright, and you get them going as quickly as you can.
Absolutely. No, I totally agree. That's a really good overview, Ben. I think the trauma service, I think it's interesting. I think certainly from our centre, a lot of what you've done is very similar as well. So if we move on to training, which I know you have a big interest in, and I think it's obviously there's been a lot of changes for the trainees as well. And what do you feel as, first of all, I suppose, the major impact has been on them, and how do you think, you know, how is this period going to be sort of, I suppose, recognised for their training? Because I know that's what's worrying a lot of them moving forward.
Yeah. So I mean, that's a complex question, but first, speaking as program director, I guess, you know, the truth is that we're all just doctors at the moment, whether you're a consultant or whether you're an F2 or whether you're a registrar. And you know, my trainees have been absolutely fantastic. They've all gone and done the necessary, same as consultant colleagues have. You know, everybody from the F1 to the consultant is acting as an SHO on the medical ward at times when it's your turn on the rota. I don't think we can recognise this period for training. I think it would be unfair on our trainees to do so. My personal view, and you know, the terms like training pause have been bandied around and so on, but I actually don't think we need to think about it in that way. We now have a competency-based curriculum. We're able to sign people off early or late, depending on how competent they are. And as such, you know, if somebody is in ST8 and clearly is ready for sign-off, then they should be signed off. If somebody is in, you know, ST5 and was scheduled to do their hand surgical job and they've spent it on the respiratory wards, then clearly they need to have that opportunity again. So personally, what I've done is I've paused my rotation. So, you know, as you know, everybody stayed in their own slots. So that rotation's become a year rotation, and everything else has moved forwards. I've done we've done a few things. We've set up a whole rotation WhatsApp group, which we didn't have, which I'm on, so I'm able to answer questions and what have you. Because always been very clear, I don't want to be on the email list and stuff. So the trainees feel they've got somewhere that they can complain about me, complain about everybody else. But equally, there needs to be a forum where they could ask quick questions. That's the first thing. Second thing we've done is we've instituted evening teaching using Zoom. So once a week they get teaching, and they love that as far as I can see. And I've given some consultant colleagues, have given some. People are happy to teach by Zoom at 8 o'clock at night, which means most people are able to make it. It's been some of the best attended teaching I've given in our program, because nobody's on call, nobody's doing this, nobody's doing that, and they're desperate to get a bit of orthopedics in. I think actually one of the things that people are learning, I think there are learning opportunities, and I think it's important to recognise that, is that people are learning how to be adaptable. They're learning how to work in teams. They're learning how to manage disasters. And, the truth is, although we're facing a national disaster, most of us at some point in our career were involved in a major acts, and the principles are pretty much the same. It's about, I think it's 18, no, something longer than that. It's about 25 years since there was the Cape of Air disaster in our own patch. There was an air disaster not so far from where you work. There's crane crashes and so on up and down the country. And actually learning how to work in a hospital that's overwhelmed is an important skill. And learning how to be good to each other and how to put aside differences with other specialties is an important skill. And, one of the things I'm quite proud of is all of my trainees have done a fantastic job of that. I've had no complaints about them. And in fact, I've only had one inquiry out of a group of 40 as to whether or not they really had to go and be respiratory doctors, and could I do anything about it. Everybody else has just been fantastic.
No, I would certainly echo that for our trainees here, and I think everybody's just really, like you just say, mucked in, and like we're all say, like you said, we're all doctors, and we've likewise found that the Zoom teaching sessions have been really, really productive, and people, like you say, attend it and they really enjoy it. If we move on then, in terms of, before we go on to the future and discuss that, in terms of research, obviously you have a strong research interest, Ben. What sort of happened from your point of view in terms of, obviously the main, like you just said, we're all doctors now, the main focus is on clinical work, which it should be. What has happened in terms of your research, in terms of the trials, have been paused and things like that?
So most trials are paused, although that's down to the CI. So I've paused most of my randomized trials. I've got 2 still running at the moment. The important thing to remember is that when you pause a trial, though, it's like pausing elective surgery. You pause new recruitment, but you still got people going through that cycle. You still need to be able to send out their follow-up questionnaires. You still need to have a trial office open so that if there's any problems can phone up. You still need to be able to deal with SUIs and that sort of stuff that comes in. So I have kept 1 day a week academic time. I'm normally 50-50. And I also run our division, so I've got 120 odd staff, academic staff, not clinical staff, working from home. So I need to provide them with some support. And I think we're just trying to eke things out from that perspective. The NIHR is going to offer no-cost extensions and so on. I think it's important to remember that if you have staff who are non-clinical, there are other things that they can do, but many of them, may choose to furlough, so their funding doesn't run out, and that's something that's important, because the funders won't pay extra salary because they just don't have the money. The second part is, there's a huge opportunity, and people should be thinking about how they can study what's going on. We've started a big tissue study we're starting on Monday, managed to get all that through in week 10 days. So we're going to be looking at frailty patients and how they do, and doing some genomics and so on. So there are some opportunities there. I think it's important to keep things ticking over. And I think it's important to keep touching base with your staff who are at home or have not much to do. Most hospitals have research associates. Most hospitals now have research nurses. Most hospitals have some form of audit department. And all of these people are, 1, very frightened, and 2, many of them are being redeployed to clinical areas in which they've never worked. And I think that's another side to it, is there's the support side to those staff who are being redeployed, because essentially those of us who are academic, like yourself, Andrew, you're their line manager, you're the person they'll turn to, and you're not necessarily, it's not top of your mind is what's happening to my research nurse, because you're worried about what's happening to junior doctors. And I think that's something just to remember.
No, that's a very good point, but I totally agree. I think so. If we move on, finally, I think sort of all those topics we've talked about, And it's very difficult, you don't have a crystal ball, but what do you anticipate the future holds for us in terms of our specialty training research, sort of immediately, but also how you think we're going to sort of come out at the end of this when hopefully things calm down?
So I think, so from a trauma perspective, I think things will just turn back on, won't they?
Yeah.
I think one of the things that we haven't touched on, which I think is a hugely important thing to remember, is we need to be planning now for a second wave of neglected older patients. You saw those heartbreaking stories in Spain, which I hope would never happen here, of all the nursing home residents starving to death.
Yeah.
Now one thing that definitely will happen is isolated older people who rely on social services support. Many of them will fall over because their carer won't turn up and they'll try and get themselves out of bed. We know from just icy weather that there's about a 2-week delay on that, so we should start seeing that fairly shortly.
Yeah.
Older people will venture out to get food, and those sorts of things. And so we're going to start seeing an increase. And in fact, we have started seeing that. We normally run 4 day trauma theatres a day at the Queen's, plus an evening theatre list, and we're down to 2. And initially we had not much to do, and now we're starting to outstrip that capacity with frailty. And I suspect next week things are going to be pretty bad, and I suspect the week after we will be having to prioritise things and really struggling. And I think that's something people need to bear in mind. In many hospitals, I think, talking to colleagues, and it'd be interesting to hear what it's like in the Royal, things aren't as bad on the ground as is expected. We had a bit more time to plan. I think NHS Central, although there's been terrible stories on Twitter which are clearly untrue of inappropriate PPE equipment being unavailable, that's just not true. What's been available is what we're told we need, and people may or may not agree that's what they want, but the NHS Central has done, I think, a really good job with the supply chain, with making sure people are where they need to be and get what they need. What it hasn't done is it hasn't thought about that second wave of ortho trauma. And I think we just need to, as a profession, take that forwards. I think in terms of our trainees and our colleagues, we're going to have a slightly de-skilled workforce. We're going to have to think very carefully about people who have done things like being out on OOP-E, come back for 3 months, and now, or OOP-R, and now have nothing to do surgically. We're going to have to think about part-time trainees who keep their skills up, but now are not able to do any surgery, and maybe didn't have as much under their belt over the last couple of years. And I think we're going to also have to think about our patients, because there's going to be a huge burden of pathology. People don't stop getting arthritis. They don't stop getting cuff tears. They don't stop getting ACL injuries, and we're going to be swamped. And the first question every patient I say needs surgery asks me now, which they never used to, is, can I have it? Can I have it non-op? Every patient is thinking, do I need to be in hospital? And consequently, there'll be lots of patients at home who just haven't come. And I think we need to think about ramping up our services and how we do that.
Yeah, no, I think that's right. And I think, like you say, I think the time is to prepare now for all that. I totally agree. Well, but I think that's all we have time for. But thank you again so much for your really interesting comments and insights today. We really do appreciate it. And we send our best wishes to you and your colleagues and their families in these difficult times. Thanks for joining us, Ben.
Thanks so much, Andrew. Bye.
And finally, as always, we'd also like to acknowledge and thank our many colleagues around the UK and across the world for their ongoing tireless efforts in the delivery of care to our patients during this pandemic. We at the Journal thank you, and we'll always endeavour to support you in all the ways we can. Stay safe, and thanks for listening.